Good morning, everyone, and thank you for joining the Children and Family Treatment and Support Services Utilization Management webinar. Before we get started, we're just going to talk about a few housekeeping things. The slides and recording will be posted to ctacny.org. If time allows, we will be taking questions at the end, so please submit questions via the chat function throughout the webinar whenever they come up. In order to do that, the chat should appear on your right-hand side of your screen. If it doesn't, you can click the little thought bubble at the bottom, and that will make it appear. So you can chat all questions, chat them through to the host and all panelists. That way everyone can see them, and we'll address as many as we can at the end. Finally, just a general reminder that information and timelines are current as of today. And with that, we're going to just do a quick look at the agenda. So we're going to start with an overview of the Children and Family Treatment and Support Services that we'll be discussing today. Then we're going to look at the basics of UM, and then we're going to get into the specific requirements of UM for other licensed practitioners, community psychiatric treatment and supports, and psychosocial rehabilitation. Then we'll go over some strategies for maximizing utilization management outcomes, and then we will leave you with some resources. And with that, I'm going to hand it over to Donna Bradbury, who's going to get started.
Thank you. Hi, good morning, everybody. So we're going to do just a quick overview, which should be by now a refresher for everybody on three of the children and family treatment and support services, other licensed practitioner, community psychiatric supports and treatment, and psychosocial rehab. And I also just want to take the opportunity to remind everybody as we do this refresh on these three services, just to frame the discussion by saying, so these three services are part of really a two-part benefit package. So many moons ago now, when the cross-agency state team first started thinking about how to approach the Medicaid redesign for children, we decided to take a two-pronged approach. And one prong consisted of this concept of expanding the array of state plan services for children and families, and the other prong is around aligning and expanding a home and community-based array. I think it's helpful just to remind everybody of that's kind of the setting for this discussion. And we're going to focus our discussion on three of the state plan services that are anticipated to go live on January 1. I also want to remind everyone that when we designed the expanded service array, we had very much in mind the concept of prevention and early intervention. This is a gap area that we believe our current service array just it does not adequately address. So when you think about these services, as I'm doing this refresh, think about how these services allow providers to identify children and families sooner, to intervene earlier, and hopefully to prevent the progression of serious mental health challenges in children and youth. And it should go without saying that all of these services are to be delivered in a trauma-informed and trauma-sensitive way, that all of these services are meant to be youth and family-driven, that they're all to be individualized to the needs that are specific to that child or youth and family, that they're to be culturally and linguistically competent, and that they're to be delivered in the most natural and least restrictive settings. So just, you know, kind of a brief reminder for everybody, and that applies equally across these three services. So on the slide, you see some detail about other licensed practitioner, and I think it's helpful when you think about this. Actually, I'm saying it's a service, but think of it less as a service and more of a billing mechanism, because that's actually what it is. I don't want to read the slide to you, so you can read what the services include, but think of them also as being services that the licensed practitioners deliver within their scope of practice. And when we talk about practitioners, we're not talking about independent practitioners. we're talking about practitioners that are operating within an organization, within an agency. And again, these services that are delivered by these professionals are intended to be flexible and delivered within the home and community, which really is the goal behind that flexibility is to make these services as engaging as possible. So many of our families that we serve are not best served within the four walls of a clinic, for example. They'd be much easier to engage and make progress in treatment if their services are delivered in their home or in some other community setting. So on to community psychiatric supports and treatment. This also is not a single service, but it's an umbrella term for multiple services, and you can see those service components listed on the bottom of the slide. This service is meant to be face-to-face with the youth and the family or caregiver and other collaterals as well. There are multiple components, which are therapeutic interventions as well as functional support. So it's kind of a nice combination of clinical therapeutic services plus supportive services. The goal here is to work with the youth and family to achieve stability, as well as functional improvement in things like skills of daily living, interpersonal relationships, and increasing resilience. Psychosocial rehab, or PSR. This service consists of activities that are much more hands-on and task-oriented rather than being sort of cognitive and therapeutic as some of the other services are. They are intended to build skills to restore a youth skills to a developmentally appropriate level. So think about a youth who, because of their diagnosis, has gotten off track developmentally, and things like self-care or coping strategies or building and maintaining a social network, skills that children and youth who do not carry a diagnosis would have very little trouble navigating. This service is meant to assist youth to restore those types of skills and get back on track developmentally. I also do want to note that these three services that I've done sort of a brief overview and refresher on are designed to complement one another more than they're designed to operate in isolation from each other. So, for example, psychosocial rehab can support community psychiatric supports and treatment by allowing for more targeted skill-building activities and help the youth improve their overall functioning. By the same token, CPST complements clinical treatment as provided via other licensed practitioner by addressing rehabilitation needs. So think of these three services less in isolation from one another and more working in cooperation with each other. So I encourage you all to, if you haven't already done so, look at the services manual, and the link is provided here on this slide, and it gives you lots of more information and lots more detail about how these services are delivered and what all the components consist of.
Terrific. Ann? Thank you, Donna. Good morning, everyone. This is Ann Cuppinger from McTac, and we're going to look at just a little bit of the background. Just a quick reminder that today's presentation is really focused on the first three services that will come online, OLP, psychosocial rehab, and CPST. But we will circle back and do similar presentations when family peer support, youth peer support, and crisis intervention come online later. So just to keep in mind that the specifics here are really related to those first three services. So Donna really pretty much addressed the background goals and underlying principles for all of this work that we're doing, but there are a couple things I'll underscore here, and that is that this is really designed, these services were really designed to allow more flexibility to meet the needs of young people and their families earlier, and to really be able to deliver services on site wherever children and families are, so that the work that they're doing is highly relevant to their life at home, their life in school, and their life in the community, with the goal of hopefully preventing the need for more intensive, longer-term, or more restrictive kinds of services. It's also very important to underscore that these services are open to all children and youth under the age of 21 who meet medical necessity criteria. So that's different from your experience, for example, with the home and community-based waiver. There are still medical necessity criteria, but it looks a little bit different. So Donna nicely outlined the core principles on which all of these services are based, and we're hoping that they're implemented with these not just in mind, but really at heart, including making sure that the family is an integral part of the service delivery and planning and thinking about what would be best for their family, that folks are working cross-systems so that these services aren't being provided in isolation, not just from other behavioral health services, but from other children's services, for example, health, school, child welfare kinds of services. And that they're done in a way that's not only respectful of the family's culture, but really integrates the family's culture and kind of identity into the treatment and support process. So a few other key points here. These are not standalone services. They're not part of an existing program. For example, they're not part of clinic. Providers must be designated to provide these services. And if you're not designated, that process is ongoing, so it's not too late. And if you have been designated to provide one service and you decide to provide an additional service, you can also expand your designation. The services, as Donna pointed out, can be delivered individually or in combination with each other or other services, and done hopefully in a way that's consistent with all of the principles that we talked about. Now we're going to talk a little bit about some of the key terms and concepts related to utilization management, and sometimes you'll hear us using the term as shorthand for utilization management. So is a set of procedures used by providers and Medicaid managed care plans to determine the clinical necessity and appropriateness of care, including the scope, frequency, and duration of services provided to an enrollee, in this case a child, in the plan. So there are a number of different components. Oh, I need to advance my own slide. Sorry, everybody. So it's getting bigger, but not going forward. Thank you. Oh, and we have, all right, everyone. WebEx has a new interface we're learning this morning. Okay, so there are a number of different components you can see in the definition there that might come into play in terms of utilization management. Not all of those will apply to every situation or every service or every child and family. They'll be used in different ways by the providers and the plans. Just a note here, if you're designated to provide any of these services, you have attested to your ability to bill both fee-for-service and managed care, but this presentation really is focused only on utilization management in the context of managed care. So there are a couple of different types of authorization reviews that might happen as a part of utilization management. Many of you are familiar with the concept of prior authorization. If you've ever had surgery or a important medical procedure, your provider would have had to contact your insurance company, seek, give them an idea of what your diagnosis was, what the treatment plan was, what they expected the course of service to look like, and then the insurance company would have provided authorization for the provider to go ahead and provide that service. And this is important in many ways. It is not required for any of the three services that we're talking about today. So no prior authorization is required for these services. There's another kind of process called concurrent review, and this is a utilization management process that takes place during the course of treatment, and it's really designed to ensure that the treatment remains appropriate. So you've been delivering a service for a period of time, and the plan and the provider want to get together and talk about whether or not that service in that amount continues to make sense for that child. Okay, so what are managed care plans looking for in terms of utilization management? Many of you have probably already seen the medical necessity guidelines that the state issued. If not, those are available on the DOH website. And they really spell out what the state's plan is in terms of what the managed care plans will do with regard to utilization management. And the plans will use those guidelines, and the idea is for them to take a holistic view of the needs of the child when they're authorizing specific services. So when a child no longer meets medical necessity, the plan and the provider will work together to make sure there's an appropriate transition plan for the child so their care isn't disrupted. So we talk a lot about this term medical necessity. And it's a pretty important concept because it's what allows the plan to go ahead and pay for the services that are going to be provided to a child. So I just want to read the state's definition of medical necessity, and that is that it means that health care and services that are necessary to prevent, diagnose, manage, or treat conditions in the person that cause acute suffering, endanger life, result in illness or infirmity, interfere with such person's capacity for normal activity, or threaten some significant handicap. So what we're saying here is that the plan will review information submitted by the provider to determine whether or not the service is needed by the child based on their diagnosis and whether it's being provided in a manner that is the right amount, scope, frequency, and duration. So we have a couple of continuity of care requirements, and the first is that the Medicaid managed care plan is not going to be conducting utilization management, nor will they require service authorization for a period of 90 days from the implementation date for all services newly carved into managed care for children under the age of 21. So there'll be this 90-day period where you'll be able to provide the service without any kind of procedures taking place. Additionally, Medicaid managed care plans are required to offer a contract to all New York State designated providers of children's specialty services or the child and family treatment and support services within the plan's service area who were formerly a provider of 1915C waivers. The idea of this is to ensure that any provider who wants to contract with the plan can, as a means of not disrupting the care of the children that are currently under their purview. And with that, I'm going to hand it over to my colleague, Yvette.
Yeah, thank you, Ann. Good morning, everyone. This is Yvette Kelly with MCTAC, and I am going to walk you through the utilization management for the new services. I'd like to start by highlighting a few key points related to the pathways to care. So there are a variety of ways in which children and youth can access these services, and the utilization of these services are intended to be individualized to the needs of the child at any point during their trajectory. And Donna spoke about that, the flexibility of these services and being able to be more preventative in nature. A behavioral health need can be identified by multiple sources, including parents, caregivers, school personnel, or the individual themselves. But for the rehabilitative services, anyone can make a referral for services, but the recommendation and service provision must be made by a licensed provider who can discern and document medical necessity. Next slide. And so since we are so descriptive in talking about a referral versus a recommendation, I just want to spend a few minutes here highlighting the difference between the two. So referral is when an individual or service provider identifies a need for a child or youth or family and makes that linkage or connection to the service provider who can meet that particular need. A recommendation is when a treating licensed practitioner of the healing arts, and you'll hear us say that multiple times, an LPHA, identifies a particular need in a child or youth based on an assessment that they've completed and is able to document the medical necessity for that specific service and includes the service on the child's treatment plan. When making a recommendation, it must be made in writing and must be signed and dated and include an explanation of the medical need for the service. If the LPHA who is making the recommendation is not a member of the program or agency, the recommendation must also include the LPHA's license number in addition to the above information. If the LPHA is making the recommendation is a member of the program or agency, then the recommendation is expected to be a bit more robust. They must also include the identification of which service components, as Donna spoke earlier, and some of those services, there are several service components. So they'll be expected to identify which of those services are required to meet that child's needs, again, based on their assessment and included in the child's treatment plan. So we talked about LPHAs. Here is a listing of the eligible practitioners who qualify and fit under that category, and so we're talking about people who are able to make a recommendation. Here is the listing for that. So this was mentioned before, and we'll mention this throughout these slides, that the first 3 service visits for the new services that are coming online in January, OLP, CPST, and psychosocial rehab, they do not require authorization. However, providers must notify the managed care plans before providing the services to ensure proper payment. And so it's important that providers are talking to plans so that they know what's the expectation around notifying them that you will be providing this service to their member. If more services are needed and the individual is seen to meet medical necessity criteria, then a concurrent review must be performed. And upon that concurrent review, the plan must provide a minimum of 30 service visits. Now, there are certain services that are not inclusive in that 30-visit threshold, and that includes fee-for-service visits or visits paid for by another managed care plan, a psychiatric assessment, and or medication management visits. Again, those are excluded from that 30-visit threshold. Multiple services received on the same day count as a single visit. In terms of the concurrent review process, this is where the provider will submit this authorization request to the plan for a medical necessity review. Again, provider has up to 3 visits before authorization is required for additional services. And I think it's important to note that those 3 visits do not have to be exclusive to just assessment. So if a provider, assessed a child in 1 visit and was able to provide the service for the other 2 visits, that is acceptable. But just a reminder that there will be concurrent authorization that is required for the 4th visit. The plan will review the authorization request with, of course, the supporting documentation to evaluate medical necessity. And currently, the state is exploring kind of a standardized form in order to, in order to supplement this process in terms of the concurrent review. So there will be more information on that. A treatment plan is required, but not for the purposes of obtaining authorization. It is required for the purposes of driving treatment. So because we like to kind of give an example of how this works on the ground, here is an example of obtaining concurrent authorization. So a referral leads to a recommendation from the LPHA with medical necessity documented. There's 3 visits that are utilized to determine the need for ongoing services. And again, before the 4th visit, the provider must request authorization from the plan to continue providing services. If medical necessity is met, then the plan will authorize those 30 visits. And again, the plans will make a the plans must make a service authorization determination and notify both the provider and enrollee of the determination by phone and in writing no more than 3 business days after the receipt of the request. So that process should be fairly seamless. Here are just some tips for a successful and efficient UM. You want to make sure that your frontline staff or the staff making those calls and submitting that documentation are aware of the regulations. You also want to attend any plan orientations when available so that you're familiar with that plan's process and information. And when calling, you want to identify yourself as a provider. You give them your name, your treating facility, as well as your ID information and the plan ID if one is given by the plan. It's also important to have certain client member information, including their member ID and date of birth. So next we'll move into the specifics of other licensed practitioner. And so you've heard this term several times throughout this presentation, and we'll talk about medical necessity and what is the medical necessity for this particular service in order for the child to receive the service, so the admission criteria. And in this case, the child must meet one or two of this criteria must be met in order for them to be eligible for the service. And so it's the child is being assessed to determine the need for ongoing services, and the service is intended to correct conditions that are found either through a screening or address the prevention, diagnosis, and treatment of health impairments. The ability to achieve age-appropriate growth and development, and the ability to attain and maintain or regain functional capacity. And again, you've heard you heard that we spoke about this before, and so this is the specific medical necessity criteria for OLP. A child in need can be referred for other licensed practitioner from a variety of routine sources, as we mentioned, from school, from other community services, or self-identification by a parent or caregiver, at which time the licensed practitioner will make a determination for the provision of service. Services are initiated upon the first visit, and the OLP will complete an assessment to identify needs that will guide treatment planning. To access OLP, the child or youth does not require a behavioral health diagnosis. Again, I just want to reiterate that. To access this service, the child does not require a behavioral health diagnosis. And again, the intent is really to try to catch children earlier on in terms of addressing their needs. So this is the one service that a child would not have to have a diagnosis in order to be eligible for that, as long as they meet the medical necessity criteria. These services are, again, intended to be flexible, so they're able to be provided both on and off-site. They may be provided to individuals, families, and groups, and again, more information regarding that can be found in the manual, which is, the link is provided in this presentation. Providers will need to build the following. There's 4 things they're going to need to build. They're going to need to build the Medicaid fee-for-service rate code, the valid CPT code, the CPT code modifiers as needed, and units of service. And again, just to reiterate, no prior authorization is required. Where the plan has determined continued services are medically necessary, again, the authorization period following those 3 initial visits must be inclusive of 30 service visits. Again, so that's important to know that. And again, there's some exclusions to that 30-visit threshold. The plan will review services at reasonable intervals thereafter to determine if what is being proposed in terms of services is consistent with their child's treatment plan and health home plan of care. It's also important to note here for OLP, within the service itself, there's a crisis service component as part of OLP, and those are exempt from those annual claim limits. There's no limits associated with any of those crisis services that are inclusive in this OLP service category. And again, this is not to be confused with the crisis intervention services that will be coming online at a later date. These are for those crisis services inclusive in the OLP service category. Next, we'll focus on community psychiatric treatments and supports. And for this, this is the medical necessity criteria for admission, and if you note, all of the criteria in this category must be met. And this is a service in which the child has to have a behavioral health diagnosis, or they need to be at risk of the development of a behavioral health diagnosis and meet all of the other criteria, which is that they're expected to achieve skill restoration in one or more of the following areas, and I'm not going to read all of those areas, but you can see that. And then the next criteria is that they're likely to benefit from and respond to the service to prevent the onset or the worsening of symptoms. And the services, again, are recommended by the following licensed practitioner of the healing arts. So again, this is a service in which the child needs to be diagnosed or is at risk of being diagnosed based on their behavior. And so for this category, they must meet all of that criteria. A child in need can be referred for community psychiatric supports and treatment from a variety of routine sources, as we've mentioned before. However, the determination for access or recommendation and service provision must be made by a licensed practitioner who can discern and document medical necessity. And again, to access these services, the youth must be at risk for the development of or have a behavioral health diagnosis. Very similar to OLP, services are able, again, to be provided both on and off-site, and actually all of the new services are able to be provided both on and off-site, and providers bill the following. CPST authorization requirements for concurrent review. CPST are services that must be part of the treatment plan, which includes goals and activities to correct conditions discovered during the initial assessment visits. Again, where the plan has determined continuous services are medically necessary, the authorization period will authorize up till 30 service visits. And again, the plan will continue to review at reasonable intervals to determine if the services provided are consistent with what the needs are for that particular family. And lastly, we'll move on to psychosocial rehab. And so in terms of admission criteria for this particular category of medical necessity, again, all the criteria must be met in order for the child to be eligible. So again, they must have a behavioral health diagnosis or be at risk. That they must have a behavioral health diagnosis that demonstrates symptoms consistent with or corresponding with the DSM, and that the child is likely to benefit from and respond to the service to prevent the onset or worsening of symptoms, and that the service is needed to meet rehabilitative goals by restoring their functioning, and that the service is recommended by a licensed practitioner of the healing arts operating within the scope of their license. This is, again, similar to all of the other services. They're able to be provided on both off and on site, and providers will bill the following, and again, no prior authorization is required for this particular service. PSR also must be part of the treatment plan, which includes goals and activities necessary to correct conditions discovered during the assessment. If the child is not yet diagnosed, a referral must be made to a licensed practitioner who has the ability to diagnose in the scope of his or her practice. And so in this case, a recommendation or a referral could be made to an OLP in order to substantiate the medical necessity for this service. And again, like all of the others, once medical necessity is determined for concurrent review, then the plan authorizes up to 30 service visits. And so with that, I'm going to pass it over to my colleague, Doris, to review some of the ways that providers can prepare for utilization management.
Great. Good morning, everybody, and thank you, Yvette. Since I'm offside, I'll just ask folks to move the slides here for me, so if you can, move to the next slide. So before I jump into the top 10 things to consider, I do want to remind everybody that these services are standalone services. We're not talking about a program, as most of us are very familiar and used to operating. And so when we think about utilization management, we do really need to think about these services as separate. They do come together, of course, for some children who need multiple services, but when we really think about utilization management and thinking about how we communicate with the managed care organization, we really need to be prepared on the medical necessity side, as you can see, there are some nuances and differences between the service and medical necessity requirement as we approach this. So with that being said, we wanted to put together some tips and some guides for folks to follow, especially those who might have less experience or no experience in the world of managed care, and especially around authorization and utilization management pieces of it. So this is in no particular order, but the first one, again, is really understanding the medical necessity criteria per service, as I indicated. And really making sure that it is clear and you understand how it applies. Documentation is one of the most critical components here. Documentation needs to be consistent, complete, accurate, and timely. And sometimes could be an issue for providers, and it's important, especially we're talking about 3 services that you do get without any pre-authorization, but then need to be able to have a communication with managed care about ongoing authorization and service requirement. And if those 3 services happen pretty quickly and you don't have the right documentation, it would be very hard for you to make the case for medical necessity if those weren't documented in a timely fashion. And of course, being complete and accurate is important as well. Examining the levels of services per service, identifying outliers. So starting to look at cases and population health. Approach here is also important, understanding why, some folks are maybe using up services quickly, others are not. It might be all appropriate, each individual and child and family needs, different intensity at a different time, but being able to examine that and look at it is important, and it's also part of the discussion that would happen with managed care. Of course, references to evidence-based treatments or best practices are always welcome and encouraged during your conversations and consideration of these services. And again, be able to provide a concise clinical presentation. That goes back to the documentation and so forth. And make sure that cases that are of concern or high risk, that they proactively, you staff those cases, you make sure that there's individualized crisis plans that are up to date, because when things happen, and they do happen, that you have a plan in place, and those are, of course, up to date and actionable. It was mentioned before already to participate in any managed care plan work groups, or other orientations or information sessions. There's really a lot that they provide. It also gives you an opportunity to, ask questions and dialogue with managed care outside of trying to obtain authorizations. It is very helpful and strongly encouraged to have a fully functional IT system that can track and report this, having ticklers, and having a system that can really assist as a tool in not just billing, of course, but of course when it comes to utilization management is very important. And be prepared for appeals, because sometimes you might need to appeal a case and know how to, staff that and how, to approach it. And bump up any concerns, meaning that if you are running into any issues, as you know, and we'll provide, there's mailboxes that you can contact at the state level to inform them, but also make sure that you voice your concerns to the managed care plans as well. And so there are a number of ways that you should be communicating if you don't believe that the things are going the way they should be going. Next slide, please. So preparing your staff is as important as preparing the agency. Your staff also need to understand the utilization management requirements, the medical necessity requirements. Make sure the qualifications of your staff are appropriate for each service and meet the criteria for each service. you know, the expectations for the review process. So one of the things we're going to be doing at MCTAC is we're going to be working, as we did on the adult side, with all the plans and trying to understand their processes. And in the hopes of putting together some sort of a tool to outline those processes, you know, who do you call, when do you call, is it a form, and so forth. I know the state, as Yvette mentioned, is working on the form as well. So we're going to try to put that all together as much as possible in a comprehensive way. You know, and starting to really kind of embrace and look into the plan's language, the tied to UM. The more you can speak that language, the smoother tends the process to go, you know, the communication is definitely much better. And practice reviews with case studies to gain comfort. So internally, you know, if you have the utilization review staff or utilization management staff that's internal, your quality staff could be helpful in running cases by and maybe getting some practice on how to this case present and look. It's important to develop internal workflows with clearly identifying responsibility. If you do have utilization management staff, how do they fit into this? How do they get information and so forth? I mentioned before, develop population-level reporting strategies, not just at the each client level. Of course, that's important as well. Routinely monitor the quality of the service being provided and look for improving opportunities. And sometimes, or a lot of times, you'll find if you embrace the utilization management practice, that could help you, you know, improve quality and expand maybe services. It's not just about, you know, as a lot of providers look at this as a way maybe for managed care to deny. But I think what you'll find a lot of times is managed care actually helping to expand the services, a look at things differently that maybe, you know, as a provider you didn't consider. So I think going into it more with an open mind is very important, especially around quality of care. Seek feedback, right? You know, from those individuals receiving the services, I think is important. And I know a lot of providers, if not all, do some satisfaction surveys. And so for the staff that will be doing utilization management, there could be the staff that's delivering the service. You might, again, have dedicated staff. You know, make sure that they're part of the treatment team, you know, and understands the full picture, not just their portion of this. They effectively communicate, as I've mentioned already. Terminology is important, and understand the treatment being provided, and it's not just extracting information from client notes or records. And this is more if you have an outside, and when I say outside, meaning staff that's just dedicated to do utilization management. You know, so a lot of times what happens is you have those staff call and just read a progress note, but really don't know the case or understand it. So it's important that they understand more than just what's written maybe in the progress note, and be very familiar with the case. In addition to being familiar with the case, is familiar with covered services under the plan, right, and understanding that piece as well. Well-informed of treatment modalities being utilized, including medication, because again, part of it is how does this service that you're trying to obtain authorization for maybe fits into an overall picture. The individual might be getting other services in other places, so it's important to have that discussion and understand that. And then, of course, as we've mentioned, you know, track the success of the service and be able to articulate, you know, the short-term goals, long-term goals, and how they, you know, going to improve the individual's and the family's life. Next slide. So with that being said, so that's kind of the tips for the utilization management. But we also wanted to, you know, just remind again, Yvette and I mentioned, the state is developing a standardized concurrent review form, so there's more information to come on that. So this way, you know, it'll be just one form. We are going to be doing office hours for billing and utilization management questions in November. So look out for the email on that and invitation for that. So this way, as you kind of process and try to understand the guidelines and the rules, we hope you'll be able to come.
We seem to have lost Boris. I'm hoping everyone can still hear us. Maybe someone could put in the chat box whether you're hearing us out there. In order to leave time for questions, we're not going to go into a lot of detail on the resources and links. The slide deck will be posted in the coming weeks on the MCTAC website under the calendar and the date for today. But you'll see that there is a mailbox in case you have additional questions. A number of links to resources that were mentioned during this webinar, and additional emails that you can use if you have questions. I'm going to turn it over now to folks to answer some questions from today's chat box.
Yeah, so we've had a number of questions come in. We have a few minutes, so we may not get to all of the questions today, but again, as Boris was saying before he blanked out, was that we are planning on doing an office hours for billing and and so there will be an opportunity to get those questions answered there. So we did have some questions come in. The first one is, has it been determined what evidence-based training will be needed by bachelor's level CPST workers in order to allow them to provide all 6 components of the service?
Hi, this is Meredith Ray-Labatt with the Office of Mental Health. The answer to that question is the state is still in the process of working on the nature of the evidence-based practices and what will be allowable under the services. The state is committed to creating a process and a mechanism for evidence-based practices, but we have not yet finalized nor completed that exercise yet. So while there is a plan for evidence-based practices to be allowable under CPST and OLP, that process and those types of evidence-based practices have not been fully delineated, and there will be more guidance to come in this area in the future.
All right, thank you. So there's a number of questions coming in regarding the 90 days of service and the authorization. And so the question is the 90 days guaranteed for every child who is recommended for a service, or only those that are beginning services after the go-live date? And again, the other question is around clarifying that 90-day carve-out.
Yep. So the purpose of the 90-day provision, first, it is applicable to any child receiving the service on January 1 and for 3 months thereafter. And the purpose of this provision is to really allow the plans time to gain experience managing the services and to ensure that there's no issues in the beginning of the implementation with accessing services and having disruptions in care. So it's really a time to kind of give everybody a chance to gain some experience with those services, and then the processes that we talked about today in this webinar would kick in after that 90 days. And that's for any service that's coming into managed care from the date in which it's carved in. There was another question below, and I'm just going to kind of jump to that one right now because it's related, asking about how this relates to the 6-month requirement that many folks are familiar with for those children who are receiving HCBS. So I just want to clarify that that 6-month provision is related to the plan authorizing the existing plan of care for children who are in receipt of HCBS, and that is that we didn't include that in the presentation today because the implementation date for HCBS is tentative for April 1st, and this presentation is specific to the 3 services carving in January. So that provision still exists. It's just not applicable here for today's discussion.
Thanks for that clarity. So there's a question around the 30-visit authorization, and so the question is around whether it's going to be 30 visits per service or be inclusive of any of the services that are being authorized. So if a child was getting OLP, CPST, is that 30 visits for that bundle of services? Yep, so as we've mentioned a few times in this presentation, these services are standalone services, so the 30 days would be applicable to each individual service that the child is receiving. Some children may receive only one of the services, some may receive all three, so it is specific to the individual service.
Okay. And along with that, there's a question around what the 3 visits equal. Is it 3 one-hour PSR services or 3 15-minute increments? I guess the question is, what is the visit?
Okay, so we consider a visit like one interaction with the child and family. So if a child is seen for 15 minutes in one day, or if a child is seen for 1 hour or for 15-minute increments, we would consider that a visit.
Okay. This question is around medication management, since it's not a service under OLP or any of the services here, and it's about the 30-visit threshold. It says, does the 30-visit count inclusive, is that inclusive of clinic visits or doctor visits for the child?
The same question.
Yeah, so medication management is not part of these services, as the person who asked the question mentioned, so that is not part of the 30 visits.
Okay. There's a question here regarding the difference between a LPHA and an NP-LVHP. So what's the difference between the role of these 2 different categories?
I can't imagine why all these acronyms would be so confusing. So the NB-LVHP, which is the non-physician licensed behavioral health practitioner, is specific to referring to those practitioner categories that are able and allowable to provide services under other licensed practitioner. There are 5 categories of NB-LVHPs that are allowable under OLP, and they include a psychoanalyst, licensed mental health counselor, licensed marriage and family counselor, therapist, licensed clinical social worker, and a licensed master social worker under the supervision of a licensed clinical social worker. And so that is what we refer to as NB-LVHP, and those practitioners are allowable under OLP, and they could make a recommendation for either OLP or other of the rehabilitative services, CPST, PSR. The licensed practitioner of the healing arts is a much broader definition of practitioners, and they are a wide list of practitioners, and I think there was a slide on them earlier, who are able to be a treating practitioner of the child. So it could actually be their primary care physician, it could be a licensed mental health clinician in the clinic, but they are practitioners that are working with the child and know the child, and therefore can make a recommendation for one of these services, whether it be OLP or CPST or PSR, because of their ability to substantiate and attest to medical necessity of the child, because they're a treating clinician or treating licensed practitioner. So it's a much broader category for individuals who are serving the child, who can then make a recommendation for additional service provision. And so it's a broader category of licensed practitioner types.
Thank you. So there's a few questions around the treatment plan for these services, and so the first question is, if a youth is enrolled in health home care management, does that plan of care replace the treatment plan?
The answer to that is no. The plan of care that's developed by the health home care manager is to basically determine what services are appropriate for the child and what their needs are, and helps to really facilitate referrals to those appropriate services. However, a treatment plan is the plan that is developed by the actual treating practitioner or the treating individual who is providing the direct services. So the treatment plan is required to be done by the OLP or the CPST or the PSR under the supervision of a licensed practitioner, and they are responsible for creating a treatment plan that is different and apart from what health home care managers do in developing a plan of care.
Thank you, Meredith. And so you answered another question that came up around treatment plan in terms of who is responsible for maintaining that. So again, it's the practitioner who did the recommendation of being responsible for it.
Right, or it's the agency and the practitioner providing the service, and who is providing the direct services and the treatment plan that they hold. And again, it could be under the supervision of a licensed practitioner, absolutely, but it's the person who's providing the direct service.
Okay. So I think we have time for about one more question. And the question is around the plans and notifying them and coverage. Are you anticipating issues with plans denying coverage if notification is not received in a timely fashion?
So one thing that, I think we need to be clear about is that even though there is no prior authorization required for these services, it will still be necessary for the provider, just like any service, to notify the plan that they are going to be providing services to a child. So that's prior to, any service being provided, just as a heads up so that that plan can set up the authorization in their system to allow for that claim to be paid. And so, we will issue more guidance around that in all of the upcoming guidance that will be coming out in the questions and answers from this webinar today. I think with these services, from our experience with some similar services on the adult side after the adult behavioral health carve-in, we have not experienced many issues with these services and plans' ability and willingness to authorize these services because these services are meant to, as we've noted throughout the presentation today, they're meant for early intervention and to prevent a child from escalating to needing higher end services, more expensive services. So these services, I think the plans are on the same page as the state in terms of using these services to really prevent the need for other more costly services. So I would say we don't anticipate any issues, but I will also say that just like the adult transition to managed care, the state will be monitoring very closely claims denials and utilization management denials of these services. And as always, we have a lot of opportunities for dialogue between the plans, the providers, and the state to kind of deal with any issues that come up during the initial implementation.
I want to thank everyone for joining us today and all of our state partners here in the room. Stay tuned for the release of questions. We realize we didn't get to everyone's question today, but those will all be considered, and there will also be an upcoming office hours type of call where you'll be able to ask additional questions. So thank you very much, and we hope you have a lovely day. Bye.